Hey, it's me, Jen again, and today you'll meet a highly ranked endocrine surgeon with a passion for thyroid RFA. We'll talk with Dr. Emad Kandil coming up. Dr. Kandil is the Chief of General, Endocrine and Oncological Surgery at Tulane University Medical School. Since completing his training at Johns Hopkins, he has lectured worldwide on topics related to thyroid surgery and published numerous papers in prestigious journals. As an early adopter of thyroid RFA, he has performed a high volume of procedures and offered numerous physician training opportunities at his institution. Over 50% of his patients travel from out of state for RFA treatment. Let's hear more from Dr. Kandil about his experience with thyroid radiofrequency ablation. So I would love to know why, as a surgeon, you felt intrigued by radiofrequency ablation. What captured your interest and made you feel like you wanted to provide this procedure for your patients?
I always believe that surgeons should not be just be able to offer an operation, and you should have different options to your patients in your armamentarium. So, for example, over the years, before doing the radiofrequency ablations, I done a lot of ethanol ablation, and actually, we had a paper coming out comparing radiofrequency to ethanol ablation. That's before the FDA approval and everything. We've done a lot of research in the lab related to different ablations, including high-intensity flow ultrasound, which is called HIFU. And I was a believer years ago that this is going to have significant clinical applications in the field. And clearly, this has been over a decade already in Europe and in Asia. So I was one of the first in the country that really jumped on this once it got FDA approved. I traveled to Italy and to Korea to learn more about it before I started. I'm a surgeon, but I do my own biopsies. I do have a very busy ultrasound practice, so I'm very comfortable with the biopsy technique. So once it got FDA approved, I did what I need to do with traveling to get exposed to what's happening, and so I can start to offer these to our patients. And I immediately brought this to Tulane. I do have the largest experience in the entire country. We are almost near 600 procedures here at Tulane. We started very early and we're far at the front. My other two partners, they offer it, they can do it, but unless you really have a passion and interest in anything, it's just very hard to excel in it. Unfortunately, there is a very little incentives for surgeons to perform the procedure. So unless you have the passion, you tend to offer the traditional approaches to your patients. Once you have this passion and people know about it, people specifically come and ask you and request that. So most of these patients are actually self-referred patients and many patients from out of state. When patients travel out of town, we try to make it very easy. So either do a visit for counseling before, sometimes even a phone call. Then afterwards, we just follow up sometimes with just phone calls. We get the ultrasound report and the labs, and we calculate the volume reduction rate and let them know about it. So it's not like they have to keep coming. So it makes it easier for them. And now with the telehealth in general, it's easier to do these communications. With experience, you get more comfort on how to do this well and do it without complications. And we have patients traveling from all over the country. It can be done with or without, and it depends on the patient, and it depends if this is covered by insurance or not. Without sedation, you have the ability to keep monitoring the voice of the patient. The idea is if you have a thermal injury and the patient gets hoarse, then you need to stop and don't make it worse. But with experience, you learn more about where is the dangerous triangle and how to stay safe. I've done hundreds of these under sedation. Usually these are done for patients who have their insurance approve this. And I honestly think it's more comfort to patients. So I feel very good about doing this with sedation. When we do it without the insurance coverage and the patient has to pay cash, cash, usually we do it without the sedation. Having said that, I'm in the process to be able to offer sedation for people who are interested to pay maybe extra cash and get the sedation with appropriate monitoring, with anesthesia in the room, with appropriate monitoring. And everybody's different. Some patients really don't want to feel it, hear about it, and stuff like this. Some patients are okay with it.
A lot of patients are confused about sedation. They think I'm being put to sleep. What level of alertness do they have when they're being sedated for RFA versus when they're being put to sleep for a surgery?
Most of the time when we take patients for thyroid surgery, we give them general anesthesia and they are intubated with a tube down their throat. So when we say mild sedation, we give the patient just something simple to make them don't remember what happened and don't feel what's going on. Similar to what someone can have when they undergo, for example, a colonoscopy. They're not putting to sleep, they're not intubated, but they get sedated so they don't feel and remember what happened. Where is the location of the nodule within the thyroid? So if it's very close to the capsule, then patients are going to suffer from some painful experience if they're awake. But if it's really inside the parenchyma, and then most probably just the pain is related to the superficial entrance of the needle, and that can be managed easily with some local anesthesia. I use the local lidocaine cream. They help with anesthesia of the skin, but you also can inject lidocaine under the skin area, but also under the muscle. But if it's near the capsule, you gotta really use significant anesthesia because it's becoming painful to the patient. So you cannot treat every patient the same. You need to know these little differences so you can really offer personalized approaches. I found it kind of scary when you have someone who did not do biopsies and all of a sudden they want to learn the technology. Well, you are not sure how to master the biopsy technique, knowing where to put your needle, and all of a sudden you're going to start to jump into this invasive technique. That's why people have significant complications. But if you master this, you can really be near 0% with the complications. And one other option, that the bigger the nodule, there are different zones. You got to make sure you burn every single one of them and burn it well. We just published the largest experience in US and the most prestigious surgical journals, Annals of Surgery. We were able to show that the bigger the nodule, the less chance it will respond well. You know, this conversation is important with the patient because they need to have some expectations of what's happening next and how much shrinkage. Some nodules can disappear, but these usually are the smaller ones. The larger one can shrink, but they also have a chance to have regrowth and recurrence. And some patients are willing to go down that route, have intermittent treatment once a year or something like that to keep shrinking and to avoid surgery. The idea is to avoid surgical complications, also the need to be on thyroid hormone replacement. But I think it's important that we really should talk to patients and give them options. You know, when you do thyroid surgery, there are different approaches. You can do this with a standard incision, you can do it with hidden incision from different parts in the body. And patients are different. Some people are more comfortable with one approach versus the other. As providers, we need to stop having this paternalistic approach to tell patient what to do. I mean, I'm happy to tell them what I would do if it's me or it's my family member, but we should give them options because everyone is different.
That is absolutely true. And I think patients appreciate when a doctor can share that perspective with them. One thing patients say the most to me is that they don't like being told, well, your only choice is surgery.
I'm a surgeon, but in some scenarios, I'm like, it doesn't make any sense except to try this. So if we really talk about, for example, the hyperactive nodule, hyperfunctioning nodule, so you can treat this with surgery, you can treat this with radioiodine, and you can treat this with a needle stick. But you need to really clarify to patients what's the expectations and what's the outcome. It takes a minute or two to burn that nodule. Obviously, you want to make sure you cut all the vascularity in the nodule, but you cure the patient with a needle stick. It's just magic. You have a very good chance to be cured with a needle stick. Why not try that? With understanding that might require another needle stick, maybe in 1 out of 6, it might not work, and then you are ready for the next step.
One common complaint we see from a lot of patients is that they're not having success with insurance coverage which, as we know, RFA does not currently have a CPT code. However, I know that that will probably be coming soon.
It's been a while. This is almost going to 3 years now, and
Yeah.
we've been hearing about this soon. I'm not sure how soon, though, to be honest with you.
I'm not either, but I just think the amount of providers who are now offering it, I have to think that the insurance companies are going to eventually get wise to that and become more interested in providing coverage for this.
I will be very honest with you. I'm not sure this is happening any soon.
Well, that's disappointing.
At least not. I mean, I like to be positive. I like to be optimistic, but
Yeah.
I don't know. I think though it's an approach that's been documented in the medical literature to be an effective and safe approach.
Definitely.
It's obviously been over 2 decades for medical use in general for liver cancer, kidney cancers, and now the thyroid for maybe a decade in Asia and in Europe. And just came to US 3 years ago. But other than that, that's different from the approval. I think it will be approved, but it might need a significant amount of time. Having said that, there are some insurers that do approve it. We always try, but you get an experience about which is which. And one time I used to write really like letters to the insurance companies saying, well, listen, if you don't approve this, especially when undergo surgery, it's a lot more expensive. And they approved it, but it's been more difficult. Having said that, we still do a good portion in our practice with patients who are insured. For sure, actually, the vast majority are. And there's a good portion with the cash payment. So everybody gets an ice for sure. We recommend to ice it the night. I used to, when we started, to ultrasound every single one before they leave the office or go home, just to make sure there's no hematoma. We stopped doing that. As long as the patient voice is good and no hematoma, obvious hematoma, then they just ice it and that's it. Do a follow-up ultrasound a month, 3 months, 6 months, and a year after. The expected outcome that usually is going to continue to shrink with time. The maximum time is usually up to 6 months most of the time, but it can continue to shrink up to a year. Most patients will plateau by 6 months. If it started to grow by 3 months or something, then you know it's not going to continue to shrink at this point.
Have you treated some really big nodules?
Yeah, I did, but I want to make sure that I'm going to offer good care here. So in some cases, if I really think that the nodule is cancerous or there's a chance of cancer with that size, I mean, you can ablate small cancers, but not very large cancers. You also need to counsel the patient significantly because it needs to have like a patient buying into this, understanding that there's a chance of failure, chance of recurrence, chance for requirement for multiple ablations. The patient think that this is going to disappear, or then I would not do it as long as there is some understanding. But many patients are happy to try and to see if this will shrink significantly. And the data is very clear that many of these patients can have good responses with significant shrinkage. It does take significant longer time. It's not one of my favorites. My favorites are the hyperactive nodules, just quick. It takes me a minute or two sometimes, or a few minutes, and you cure a patient from their disease. Cancers ones, small cancer, are very easy to treat, but these very large masses takes a long time, and you're not sure yet. You're gonna wait and see. The huge ones have higher chance of recurrence, or maybe what you would consider failure. The question is, what's failure? Failure definition is very variable. Sometimes we consider it failure if it shrink less than 50%. But maybe some patients are happy to have a volume reduction rate of 30% and willing to do more sessions. And then we published recently in Annals of Surgery on the elasticity, how stiff is the nodule. If it's very stiff, then maybe these are the ones that will respond less, and maybe we should not do that. Some patients will have maybe 3 sessions,
Really?
but they are willing, they are happy. Been doing this for 3 years, so they have a response. For example, start to and grow. They want to do it again instead of surgery, so they are happy to do it again. You do a session to shrink, another session is working, and then they say, well, the response is not as good anymore, start to plateau. Then they want to hit it one more time. Basically, radiofrequency ablation is a heat that create an energy that leads eventually to the death of the cells. But if you have a very large mass, the cells are going to support each other and keep regrowing. So its chances are higher for failure or for recurrence when you have a very large mass or you have a very vascular nodule, because it can bring the nutrients, the blood supply, to grow it.
Yes, I think that I've encountered one patient so far who's had to undergo 3 sessions. I underwent 2 sessions. I was interviewing another doctor recently who was dealing with a patient that was planning to undergo 3 sessions. As unfortunate as it is that patients sometimes need that many treatments, I think a lot of patients are willing to do that because they want to see if it's possible for them to avoid surgery.
In the 2 visits that I did to Italy and Korea, I've seen patients that already getting, one I think was getting like almost every year a session. So it was like maybe it's either her 4th or 5th session in Korea, and in Italy was like a 3rd time or something like that. So it's not uncommon. You just get comfortable. You know you're going to do a good procedure. Patients appreciating that. They don't want to do surgery. So
let's touch back on cancer. That's a very important topic right now in our community. Patients that are looking for RFA providers that will treat cancer are becoming more and more common.
yeah, I'm very comfortable doing it, but you need to choose the right patient. One of my patients shrunk like 95% after that. And we do have many great success stories. It's about counseling. So if the patient is understand that maybe if it doesn't work, then surgery should be an option. For the last few years, active surveillance is an option for patients with cancer. Active surveillance meaning that you know that the patient has documented cancer, but you think that we can just monitor it, making sure it's not growing, it's not spreading. In my opinion, why not offer something less aggressive than surgery, and you are doing something before something happens? So there are a lot of patients like this. There are patients that have been doing their own active surveillance with their sometimes local endocrinologist. And when this option is out there, they are interested. They want to do something, but they don't want to be aggressive, like having surgery done. And we need to respect that decision, because active surveillance is an option. So if it does work, then that's great. At least you're feeling that you did something to it. And this will depend on molecular markers, and a lot of the research that I do in general is related to that, finding the molecular markers that can tell us which one will eventually progress and which one will not. You know, we're still depending on very primitive markers like the size, the shape, and the ultrasound, stuff like that, which we know that you can have very small cancer that can be very aggressive and metastasize, and large cancer that's not. The difference is really on the molecular signature of the tumor, not just the size. Size is a very primitive thing. It is a factor that we use in staging, but it's not just the size. But again, you need to look at the entire picture. So first of all, it has to be like a small cancer. You want to make sure there is no evidence of a spread. Your patient had a good comprehensive neck ultrasound. Patient is motivated and compliant, that they're going to follow up. They're not going to just have the ablation and just disappear from this world. So they're going to follow up with appropriate follow-up and with the appropriate care to make sure if things are not doing well, they need to then go down the route of surgery for sure. But the data is very clear that the outcomes are very impressive in these patients, and I think it's the future. And what we know, that patient can live with our cancer and maybe just live with it and die with it, but not everyone, but many patients. So why not just offer something minimally invasive? The best part is that usually these cases are the easiest ones for radiofrequency ablation, because the tumors are not large and small. There is strong data, very good data on ablation of metastatic nodules, the cancer already spreading, and you have cancer in the lymph nodes, and you can clearly ablate this. And we've done this here at Tulane. You go in with the needle into the lymph node and kill it. Patient's high risk, your marker for cancer will disappear. So you definitely kill the cancer on that patient. I had a patient who had a metastatic cancer to the lymph node, but then he had also lung cancer. So he's not going to die from this thyroid cancer. He's going to die from his lung cancer. So I was able, without surgery, to offer him the ablation. This way I can avoid the surgery altogether. I have this under control so he doesn't have something growing, cancer growing in his neck. In my mind, I offered him a big favor. Can I do the surgery? Yes, but it's just a big operation with neck dissection. And I'm not sure if I'm really offering the best care to this patient by doing the surgery, because he's just not going to die from this. Personalized treatment is very important. This is not considerably very novel anymore, I think, and it's not something that we're going to try to see if it works or not. It's been tried, it's working. It's the present and the future. But what's really interesting that the indications are just keep expanding and expanding. I think experience does matter because there is a learning curve for physicians who are offering this. And I'm hoping that it's just going to be something that we are not going to keep fighting insurance with in the future, and can be something that any patient can use.
Tell me about your trainings that you're providing for physicians at Tulane.
We are actually doing a course with NASIT, the North American Society for Interventional Thyroidology, like offering certain courses where we have a small number of physicians. They come in, they go over the technique and with the lecture and stuff like this, and they have hands-on and they observe the procedures. We do like 12 cases within a few hours so they can see them while they also try to practice. I think we've done maybe so far 4 or 5 of these so far, and it's been good. It's been very successful. We had good feedback. It's just fascinating, but we're just witnessing history. I remember, historically people used to say laparoscopic surgery, why you need a scope, you can just do it open, and now minimally invasive, robotic, and all this. And it's so funny how things that are currently the standard of care for years, people used to fight it and argue against it. And this is happening with RFA. How long it will take, though, I don't know. And I think it's about education. Patients really trying to learn more about the options, and educated physicians who knows about this, and they're trying to refer the patient to the right path.
That's what I'm trying to do, is just, through our community, to educate patients about this and help them educate themselves. That's why I have the channel providing educational content so people can make informed decisions about their treatment for their thyroid nodules and cancers. One thing we're trying to do right now is get a website up and running with the list of providers, because currently that list is only available inside of our Facebook community. And we know there are a lot of patients that are not on Facebook today. So we want to provide that information to anyone who wants to find it, not just those patients that are on Facebook. So that's currently what we're working on. Hopefully we'll get that going in combination with getting our nonprofit off of the ground.
They're doing a great work. This is huge. You're trying to avoid thyroids coming out when they can avoid a simple procedure. 15% of women after total thyroidectomy, they will never feel normal again, despite
Exactly.
the hormones, despite they are compliant, despite their levels are okay. Nothing like your own factory. Nothing like your own hormones coming out of your own factory. You look at, there is always updated guidelines and controversial issue about how do you replace the thyroid hormone? Do you give T3 and T4? Only T4? How much? And all this. And just something always debatable. There's too many debates on what to do and how to do it, which clearly means that we are not solving the problem yet, or we don't know how to fix this problem yet, and the problem's still there. To avoid the problem altogether is just a big deal. And this is one of the things, honestly, just undergoing general anesthesia, undergoing surgery in the best hands with the extremely low risk of complication, near 0%, it is an operation.
It's not a small thing, so avoiding it when you can is always preferable.
Absolutely.